So today we're gathered to talk about ADHD, a little bit about the diagnosis, treatment, and some tools that work, as hopefully our title suggests. To just give you an idea of who we are, I am. Well, for whatever reason. Okay, there we are. I am Dr. Michelle Maegly. I am a psychologist and have the role of clinical director here at Hello Mental Health. I've been a psychologist since 2010, worked at the state hospital for about 10 years, where we were woefully undertrained about neurodivergence of any type, especially ADHD. And it wasn't until the last couple years where I joined private practice full time that it became a passion of mine and an area of interest, and I'm seeing it everywhere in the clients that I'm working with. And I'll let
Hi.
Kristen, Dr. Baus, introduce herself.
Yeah. Hi, I'm Dr. Baus. I'm a psychiatrist, trained at UC here, and then have been out in Omaha, at UNMC for the last 10 years, and came back here about a year ago. Uh, I'm working here now at TrueCare Physicians, with a psychiatrist friend from residency. And yeah, I've had an interest in ADHD kind of in our outpatient clinic out in Omaha. We were seeing people that had kind of a lot of times been previously diagnosed with other things, and we were seeing it more and more in adults that maybe weren't diagnosed as kids. And I'm here to talk a little bit more about like medication options.
Excellent. Great. Well, we are so happy that you're here. I know that it is hard to find time to carve it out for yourselves. And so your presence here is really meaningful. Appreciate that. So, we are under the assumption that you're likely here because ADHD is a part of your story somewhere. We wanted to make this training accessible to individuals who are living with the diagnosis, individuals who are curious about the diagnosis, as well as providers who are working with folks who have this diagnosis or this experience as a part of their life story. So appreciate that you're here. I want to kind of give you a roadmap of what we're going to be doing today. So we're going to be talking about the why, what ADHD is, what it isn't, some internal experiences, also what to expect from the diagnostic process. Then we're going to be talking about the how. What are some medication options? How do those medications help? What are some of the drawbacks of various medication choices? And then at the end, we're going to be giving you some actionable strategies for the things that people we see struggle with in our practices and things that, may not be targeted by medication that people we find are still struggling with. If you have any questions, feel free to go ahead and put those in the chat. Bailey will be monitoring those and she'll let us know. Let's move on. Let's get started. So, when we think about ADHD, we want to remember that it is so much more than just being distracted or hyperactive. Those are really the surface label that come along with the diagnosis, but we want to talk about the internal world, the experience that other people don't see. And oftentimes, it seems as though the clients that I work with don't realize that some of these things are part of having the diagnosis. So the first one that I have listed here is mental static. So that's sort of that constant low level hum in the brain. I liken it to having 50 browser tabs open at once, but you can't quite find the one that's playing the video in the background. And if that video would just be muted. So it's that noise in the brain, and it's not necessarily just external distraction, but it's internal distraction. The second one is this frustration that people have of knowing that they are capable, knowing that they have the intelligence, they have the skills to be able to accomplish what they want, but they feel like they're being held back by, some type of invisible force. I liken it to having one foot on the accelerator and another foot on the brake at the same time. So there's that disconnect between knowing what to do and actually being able to make it happen. And what happens there with that is that can really trickle into what we call a shame spiral. So when somebody sees that they're capable, for whatever reason, they're not able to follow through. In their mind, we would liken it to ADHD when that's what we're talking about. But they see things like I'm forgetting things, I'm missing deadlines, I'm losing things again. We will often have this internalized message of you just need to try harder. Just organize better. And it leaves a person with this heavy, draining feeling of not being able to meet expectations, not just others' expectations, but one's own expectations. And then we have a term that I recently learned, I thought was really fun, is the wall of awful. So it's this idea of staring at a simple task like an email or laundry and feeling completely paralyzed. It's not about wanting to do it, and it's not necessarily avoidance or denial or whatnot, but it's just the fact that a person's brain won't initiate the task and it becomes agonizing, this feeling of being stuck on something that in our minds we think should be easy. So, for many of our clients and those of us who live with ADHD, as I am one of those individuals, these things feel very familiar, but we want to make sure that people realize that these things are not their fault and there are reasons why that is the case. So this takes us to brain wiring. So what's actually going on? At its core, ADHD is a difference in how the brain is built and how it manages itself. So we have it labeled as a neurodevelopmental condition. So brain and development, how the brain grows and matures. It isn't a temporary state. It is a different blueprint for the brain's operating system. I don't know about you, but I will have clients who say, I think I grew out of my ADHD diagnosis, or, my husband, he had ADHD as a kid, but, that was as a kid. It's probably not happening now. It's not temporary. It's not something that people grow out of. It really is a difference in how the brain's self-management system is hardwired. So we call these executive functions, and we think of it as the brain's CEO or air traffic control center. So executive functions are responsible for focus, for impulse control, emotion regulation, getting started on tasks, and planning. And I think the crucial piece that oftentimes we miss, not necessarily as therapists, but just as a society, is that these things are not a choice. It's not a lack of willpower. It's not a character flaw. It's not the result of poor parenting or too much screen time. This is not somebody being lazy. And it is this foundational truth that this is a brain wiring neurodevelopmental issue that we are going to be building everything else on that we talk about with ADHD. So when we think about causes and risk factors, some folks don't realize that ADHD is one of the most heritable conditions that we know of. It's very common to see it run in families. If you have it, or if a child gets diagnosed, there's a strong chance that a parent or a sibling or another child does too. I actually have clients in my care that will come to me and say, "Oh, yeah, my kid got diagnosed with ADHD, but when the assessor was talking about it, I felt like they were talking to me too." It's like, well, they probably were. So it's highly heritable. When we think about environmental factors, it is important to realize that the factors from the environment increase risk, but they are not standalone causes. So these could be things like premature birth, low birth weight, prenatal exposure to toxins, significant early childhood trauma. They can increase the risk, but they are not causes. And really, with brain development, we see these observable differences in the brain structure, the wiring, and especially in those networks that act as a manager. So it isn't brain damage, it's just a different developmental pathway. So, how does a person get to a diagnostic label? How do we come up with those? When we do a psychological assessment as psychologists, we will often use some combination of what I'm going to be talking about. Each practitioner, whether it's nurse practitioner, primary care physicians, behavioral health specialists, psychiatrists, we have our different ways of getting to the diagnosis. And there really isn't a standardized way of doing it. There are things that people learned when they were in training, and then there are things that the most up-to-date research has been showing us. So I think of these things as, the core components of getting to that label. So it starts with a deep dive interview. This is a comprehensive conversation about life story. We want to be looking at challenges across home, work, relationships. And a big focus of the interview is on childhood and school experiences, looking for the lifelong pattern, because it often shows up early on. And I think the benefit of seeing it early on is it's much less likely to be entangled with other struggles that a person may have. And we'll talk more about that as we move on. Another big component of an assessment, especially the ones that I do, are standardized tools and questionnaires. So these are scientifically validated tools and symptom checklists. It isn't just a casual chat. I had one practitioner tell me the other day that, screeners are great. Well, these aren't necessarily screeners. These are validated tools. And it is to help rule out other diagnoses. It's to help find things that might look similar and really to provide a structured way to measure symptoms consistently and objectively. And then another component is collateral information. If a client gives us permission, we'll seek out information from a parent, from a child, from a partner about a person's current challenges. So it's not about checking up on them, but it's about getting a fuller picture of how symptoms show up over time. And the goal is really to gather enough information to see the clear lifelong pattern and ensure that the diagnosis is accurate. And sometimes people will ask for additional testing, or we will see that it's a really complicated diagnostic picture. So we'll add on specific tests in order to try to suss out what might be ADHD, what might be another neurodevelopmental condition, what might be a different mental health struggle that a person is dealing with. So that's how we get to the diagnosis. So when we're looking at core symptoms, these are the cluster that we're all aware of. There's inattention, the hyperactivity, and the impulsivity. These can show up in different ways. And it wasn't until I started doing some more in-depth training into ADHD that I realized some of the very specific ways that these things can show up as. And oftentimes when we're doing a diagnosis, it's not oh, I have problems with forgetfulness or distractibility, but they'll say something else like, I can't sit through a movie with my partner. I start to get on my phone and I lose track of what's happening. So it's really in the stories that we listen for these things. But it can help to have very specific examples of how ADHD does affect daily life. So what do we see? Common challenges, like we said, disorganization and forgetfulness, losing keys, losing documents. My grandmother, she always lost her glasses and she would lose her teeth because she wouldn't put them in the same place. And I really, looking back on it, I think she likely had ADHD. But I remember she and my grandfather getting into arguments. If you'd put them down in the same place every day, you wouldn't lose your teeth. But yeah, so that was a fun one. But another one is procrastination and missed deadlines. So leaving things to the last minute despite best intentions. I like to think of it as, in order to get a task done, a person has to feel pressure, pleasure, passion, or pain. So there has to be some type of external motivating factor that helps people get started and get things done. There's also the fidgeting, restlessness, the internal energy that needs to get out. And then also this difficulty sustaining focus. So this might be the person who's tuning out in meetings or in conversations. One thing that I discovered is during meetings that doodling would really be helpful. My fear was always that I would be perceived as being tuned out because I was doodling, but it actually helped me focus on what was going on in the meeting. So these are some of the more commonly known challenges. There are also some less known challenges that are very common with ADHD that I'm sure many of you have heard of. So one is time blindness, a poor sense of time. 5 minutes can feel like 30, 2 hours can feel like 15 minutes. This can lead to people being chronically late or having significant time anxiety, having a hard time estimating how long something is going to take. Another one is rejection sensitivity dysphoria. I think this one is really important for those of us who are therapists. This isn't about just being a little sensitive. This is an experience of intense, overwhelming emotional pain in response to perceived criticism, in response to perceived rejection. It can leave people to become people pleasers to try to avoid this feeling of rejection, but then they can lose themselves in the process. We also see emotional dysregulation. So emotions come bigger, faster, they're harder to manage. The anger, the frustration, the joy is intense. And, it could feel more like a switch going from 1 to 10 instead of a knob that turns up and turns down. And then the last one, and this might be one of the ones that my clients directly complain about the is this is that task paralysis, that wall of awful that we mentioned. It's that freeze state for tasks that you want to do. It's almost as though the starter on your engine won't turn over. It leads to a lot of frustration, a lot of shame. And so, understanding these experiences, the full picture, how it affects daily life, is really what makes an ADHD diagnosis so validating and life-changing. It helps connect the dots across a person's lifespan. All right. So we already talked about this, so I'm not sure why I got that slide in there a second time, but that's okay. But here are some insights on the diagnostic journey. So late diagnosis is common, and it can come with both relief and grief. Sort of relief, it's not just me, it has a name, I can finally understand. Some people find community, but then there's also the grief. Like, if I had known, what could I have accomplished? How different would life be? Both of these feelings are 100% valid. They often exist together, not one separate from the other. Another insight that we've noticed with the research, as well as my lived experience as a therapist, is that people are often diagnosed with anxiety or depression first before ADHD is even considered. And what we see is that anxiety and depression are frequently the consequences that go along with unmanaged ADHD. So if a person is anxious about forgetting things, missing deadlines, letting people down, how they're being perceived in the workplace, or maybe they're depressed from the sense of underachievement and shame that comes with it. And so we can often see folks being treated for anxiety and depression, and it doesn't mean that they shouldn't be treated for those things. Certainly, that can be helpful. But if they aren't able to get at those unmanaged ADHD symptoms, then we're really missing a root cause piece of the picture. And then really thinking about clarity instead of labels. So ADHD and getting that label is or sorry, it says not a label, but we're looking for the clarity more than anything else. We're replacing the idea of what's wrong with me to how do I work with my brain and not against it. So that diagnosis can be the first step to self-compassion. It can be a step toward feeling this grief, feeling relief, finding the right tools and strategies. And we really want to help them work in a way that supports their brain functioning and their neurology. So that's how we get the diagnosis, and that's the beginning of the journey. So what do we do with it? So we're going to be talking about the tools. So there's the medication, regulating brain chemistry, and then psychotherapy, which is where we build the skills and strategies. So I want to hand it over to Dr. Baus to talk about medication and what happens at a psychiatrist appointment.
Hi. Hey, so yeah, I thought I'd go through kind of, I know there's a lot of therapists in here. I know kind of what happens like when you go to see the psychiatrist. What does that look like? And so first of all, like the first appointment is usually about an hour long, sometimes a little bit longer, sometimes a little bit shorter, but not much. And basically, it's going to be a lot of the same kind of questions, like a pretty thorough history. Again, we're also going to ask a lot of questions about your childhood, trying to also kind of get that history that this is like a lifelong symptoms and that this has been something that's been going on for a while. And then we'll probably talk more about specific symptoms, things that brought you in, like what's going on right now. Like Dr. Maegly said, a lot of people are diagnosed with depression or anxiety. Sorry, I was reading the question. A lot of people are diagnosed with depression or anxiety first, and sometimes that, I would say about 30% of the time, whenever I see somebody with ADD, they come to me with anxiety first. And then as we're talking, just getting more and more symptoms that sound an awful lot more like ADD. Because again, yeah, it is that thing that like people's minds are going really fast. They're kind of thinking about other things while they're trying to do one thing, or they feel really anxious that they can't get things done. A lot of people have rigid systems that they've had like since high school about like doing this and this and this, and they're really unable um to like change those really rigid systems at all. So maybe they even get diagnosed with obsessive compulsive disorder or something like that. And then kind of depending on what's going on, We may also ask for like additional testing, often maybe send people to Dr. Maegly or to Hello Behavioral Health for like additional psychological testing. And then sometimes also kind of working with people's primary care physician if there's some other medical kind of thing going on that you have a concern about, asking for blood work or something like that, although that's kind of rare. All right. So, okay, so we've gotten to our ADD diagnosis here. Kind of want to start some kind of medications. So there are 35 or something different medications that we can pick from. So how do we choose which one we want? Number one, we go through exactly which symptoms you want to target. Number two, side effect profile. So this is kind of what I'm thinking about. Like, can somebody handle different side effects? And we'll go through different side effects of different medications. Number three, we're going to think about the cost. Patient can't afford the medication, or it's causing significant distress to their family that it's not the right medication. And then finally, kind of the method and timing of delivery. So there are, especially the stimulants, come in a multitude of different formulations, and they are all kind of timed differently. And some people are more comfortable taking something that starts right away. Some people would rather take something that starts later. Some people kind of want a smoother onset that lasts all day. So that's something I can talk about too. All right. So, and if you have any questions, please let me know. Okay, these are the types of medications. These are kind of the different classes. So with the stimulant medications are kind of the classic medications that we use for ADD. And then there's also the alpha 2 inhibitors, clonidine and guanfacine, guanfacine also called Intuniv. And then there are like the non-stimulant medications, Wellbutrin and Strattera. And then we also use antidepressant medications. They're kind of an off-label use. Specifically, Wellbutrin is the one that's used most often for ADD. All right, so the stimulants, there's really just two molecules, basically. There's like the one that's in Adderall, the amphetamine, and then there's the one that's in Ritalin. And so if you have any specific question, like, so Adderall comes in all these different formulations. What I wanted to do here is just kind of list them out. There's too many to go through every single one. It would be long and boring. And so some of them are come in like liquid, some in oral disintegrating tablets. Some are sprinkles that you can put in applesauce. Some of them come in patches. Some of them last for a short amount of time, just a couple of hours, whereas other ones can last, like Vyvanse will last for 16 hours, lasts all day long. Jornay is one that you take at night, and then it starts working in the morning. And so there's kind of all different formulations that your psychiatrist and you can choose from.
We do have
Okay,
a couple of
so
questions in the chat about meds, if now would be a good time.
yeah.
One of the questions, one of the participants said that they have a daughter that takes Focalin, which makes a huge
Mhm.
difference, but because it suppresses appetite, they have to play around with the timing of it. And they were asking
Yeah.
if there was a med to increase appetite or if there's other strategies.
Usually what we do is just kind of play around with the timing of it. I mean, there are medications that can increase appetite, but generally what we do is try to mess with the timing of it so that it wears off kind of by dinner time. And then I don't know how old your daughter is. I know with some of my patients that are like older teenagers, that's a little bit of a problem. That's when they want to do their homework then is after dinner. One thing that I've done is switched actually to a different medication that's not a stimulant medication that doesn't interfere with appetite. So that's an option.
And then we had one more medication related question. Is medication
Yeah,
always involved in the treatment of ADHD?
that might be a better medication, better question for Dr. Magley. If somebody's coming to
Sure.
see me, they probably want to start medication.
Yeah, I would say that I probably 50-50 of the clients that I work with and that have diagnosed ADHD choose to be on medication. I have a diagnosis of ADHD and I'm not on medication, whereas other people that I know, they do and they can't function without it. So I think it really depends on what kind of strategies they have in place, what kind of demands they have on their life, what kind of external structures are imposed, and what's going to really set them up to be the most successful. But no, I would say that medication is not always involved.
Okay, we have two
Okay,
more med related questions.
sure.
And then maybe any other ones we'll revisit at the end. So one question was, I think the question was about people seeking medications for ADHD, and I think difficulty with prescribing medications for people seeking those with ADHD, even though their symptoms maybe look more aligned with bipolar disorder, trauma, or depression.
What to do in that case, kind of, if
I
somebody's taking
think so.
medication for
Yeah,
ADD?
an increase in people seeking ADHD meds, thinking that it's ADHD when maybe their symptoms actually better align with a different diagnosis.
I can speak to that a little bit. I think that
Yeah.
when these diagnostic questions are a bit more complicated, that's when I get referrals from psychiatrists who are wanting to really suss that out in a more structured, validated way because it's really hard. And the last thing we want to do in an interview is to invalidate a person's trauma. But also ADHD and trauma can go together as well. So I think that's where we really look at the historical picture if a person can remember that far. And I've also had people with depression, say, wow, a stimulant would really give me more energy for my depression, but they don't have the history to really support an ADHD diagnosis. So that's really where testing can come in and try to clarify some of those answers.
I think that's true. And sometimes for a brief period of time, we might use a low dose of a stimulant in depression. And then also, I was just thinking, Dr. Maegly, if you want to go, can you go back like a few
Yeah.
slides, one of your slides? This is an interesting question. A lot of these things, like the less talked about realities here that you were talking about, those are the things that go along really well with trauma. The rejection sensitivity, the emotional dysregulation,
Mhm.
the even like the time blindness can sometimes actually be more something like can all definitely go
Dissociation.
along. Yes, dissociation. Thank you.
You're welcome.
Yes. So dissociation, yeah. Yeah, those things can all go along with trauma too. And it can be really hard to figure out like, is this ADD or is this trauma? So yeah, that is something that I would send somebody to Dr. Magley to talk about. And it doesn't mean it's not real or that it's somehow your fault or something then if
Mhm.
it's trauma and it's not necessarily ADD symptoms. It does mean that the stimulants are not going to be as hopeful though.
One more med related question, and maybe this is one we
Yeah.
can circle back to at the end. And selfishly, I would love if this becomes its own brand new webinar. But the question was about newer research related to adjusting stimulant medications during a woman's menstrual cycle, or specifically in perimenopause.
Oh, I don't know if I know a lot about that. I'm sorry to say. I think my colleague, Dr. Jones, might know a little bit more than I do. Yeah, that would be a really interesting webinar.
Stay tuned for
So
future
something I need to learn
programming.
more about. Thanks
Yeah,
for asking.
great question.
Okay, yeah, so I'll finish going ahead kind of through. I feel like the questions I've gotten are a little bit more sophisticated than what the slides I have. So, stimulants, what do they like? They help with the core symptoms of ADD, the inattention, like over arousal kind of symptoms that people often feel like they can focus a whole lot better and that their brain isn't lighting up everywhere. And then the impulsivity. They help like 80 to 90% of people diagnosed with ADD do have a significant symptom reduction with stimulant medications. And then another great thing about them is that they start working immediately. Well, I wrote for psychiatry. For a psychiatrist, they start working immediately. We're used to things working in like 2 weeks. It's maybe like a half hour, an hour, something like that, depending on the medication. And then the other great thing about them is that if you're having any side effects from them, they wear off by the end of the day. So like side effects go away. All right. So what's not good is we've already talked about like height suppression, and that can really be a problem, especially for kids. Possible sleep disturbance if you're taking them late in the day, it can be hard to fall asleep. There's that kind of evening crash. A lot of people don't notice it, but then I'd say maybe about 20% of people it can really feel when their stimulants wear off in the evening. And then especially that like emotional dysregulation, they just kind of feel a little bit more irritable, have trouble, yeah, paying attention, or getting tasks done. And this is especially noticeable for people who have kids and are trying to manage a lot of household stuff, and kind of that evening kind of rush when they're on these symptoms. And then also it's a Schedule 2 controlled substance, which just makes it kind of a pain in the butt to get it from the pharmacy. You have like can only get 30 pills at a time. Sometimes they're really difficult. It can be really difficult to make sure that you get it filled. It has to be filled within a couple of days of it being due. It's hard to get it if you're going to be going out of town, that kind of thing. So next, so if you don't want to be on a stimulant, if those aren't working for you, or the appetite suppression, there are a few other options. One is Quellbry and Strattera. I kind of put them in the same group. They are non-stimulant medications that we use to treat ADD. They help with those same core ADD symptoms we talked about, the inattention, overarousal, impulsivity. They are nearly as effective. They work on more like 70% of people. And then they have that kind of smooth action over time where it's not like wearing off in the evening and then you got to take it again in the morning. So people don't have that same kind of experience where they have the crash or anything at night. Problems, it takes a lot longer to see effects. A couple of weeks for the Quellbry, 6 with Strattera. Again, they're not as effective in as many people. And then some people can have like GI upset. Some people get tired when they take the medication, although that's not usually a big issue. You just take it at night before you go to bed. Some people feel a little bit dizzy when they take the medication. But by far, the biggest issue that we have with it is that it takes a few weeks to a month for it to to start really feeling the effects. And then next we have like clonidine and Intuniv are often used with the stimulant medications, although sometimes used on their own, probably more in kids than adults, but they help with like overarousal and impulsivity. These don't really help with the inattention as much. So but they can help people that are really anxious or feeling like they need to be moving all the time, that kind of thing, to be able to calm down. Clonidine we give a lot before bed. So it can make people kind of sleepy, and then they're both like blood pressure medications, and your blood pressure can spike if you dose. So if you're on it with the stimulant, we try to manage blood pressure here. And then finally, the antidepressants. So tricyclic antidepressants, and then most common one would be Wellbutrin or bupropion. And these are used pretty frequently, I would say, in ADD, especially the Wellbutrin. So it can help with all the core symptoms of ADD. Also treats depression and anxiety at the same time. Works to like significantly reduce symptoms in about 60% of patients, which is most people. And then I would say the biggest reason that we use these is that people kind of feel like there's a stigma or they don't want to be on specific ADD medication or they're just not comfortable with that. And then kind of out of those, response is delayed. They're not as effective as stimulants like for most people, but Wellbutrin's a really good option. Okay, and then finally, like what medications can't help with. So even if we have the right diagnosis, you're on the right medication, we still might be sending you over to telemental health to get help with some other things. So one is just like that executive functioning stuff, organization, planning. It can help you feel like you're able to organize things if you want to organize things, and that like kind of wall keeping you from doing things is no longer there. But it can't actually teach you how to do that if you haven't really had that as part of your life before. They don't make you smarter. They can't help with problem solving or memory. People don't tend to do like kids that take these, they get better grades in school, but they don't tend to do any better on tests or anything whenever they're not taking the medication. They do better because they do better with the task initiation and then completing tasks. Doesn't help with relationship patterns with other people. Well, it can help a little bit with relationship patterns with other people because you're able to pay more attention to conversations that you're having with people. You don't have that emotional dysregulation. It's not going to fix kind of core problems or difficulties that you might be having. And then it doesn't help with feelings of, you know, those feelings of depression, anxiety, guilt, the perfectionism, kind of the things that stem from having maybe an undiagnosed childhood ADD are something that the medication is going to help with, and that sometimes people need to go to see a therapist to work out more. All right, so that's kind of the end of mine, but I'll turn it back over to Dr. Maegly. Thanks.
Excellent. Thank you so much. Great information. I said earlier about myself having the diagnosis and then I'm not treated. And then you mentioned Wellbutrin. It's like, well, yeah, I've been on Wellbutrin for the last 15 years. So I guess I am treated to some degree. But thank you for that. So once a person gets the diagnosis, once they have met with their physician, if medication is something that they want to pursue, then, how do we handle those other issues that the medication doesn't touch or the consequences of not having been treated earlier in life? So I wanted to make sure that we gave you some very specific strategies that you can take home. So the first one in our toolkit is we want to talk about the 5-minute rule. So the 5-minute rule is essentially don't think about the whole task. Commit to doing something for 5 minutes. Anyone can do anything for 5 minutes. Could be set a timer, tell yourself, I'm just washing a few dishes, or I'm just putting on my shoes or my gym gear for me. Basically, starting is often the main barrier and momentum will carry you forward. This is also something that we do for depression and behavioral activation, getting someone started. But it's that oftentimes with ADHD, somebody may overestimate the amount of time a task is going to take, or they overestimate how boring it's going to be. And so the 5-minute rule can really help a person get started. The next thing is externalize everything. So what we mean for this is that it's to deal with the mental clutter. The concept is your brain is for having ideas, not for holding ideas. So the moment a thought or a to-do or a reminder pops up, do what you can to get it out of your head. Use a notes app or a physical notebook, a whiteboard, voice memos. This can help clear some of the mental static and you can use it to build a system that you trust. You pair this with some of the organization that you might be taught or that you might see on social media or that you might develop for yourself over time. One of my favorites is the transition basket. So, for example, if you're anything like me and you're working in one room and you see something that needs to be put away in a different room, you go to that other room and then you see 3 more tasks that need to be done. So the transition basket really helps with this. When you're cleaning a room, don't get derailed by items that belong elsewhere. So instead of making those 10 trips to 10 different rooms, just put them all in a basket. Once you're done with the room you're in, then you can take the basket to the next room and be focused in one trip. So it basically contains the chaos and stops you from walking into another room and getting distracted. Another one is body doubling. This is something that has become more and more aware of people talking about this. It used to be that clients had never heard of this, and now more and more people are hearing about this. So body doubling is essentially, it's kind of like parallel play. It's the effect of having another person quietly working beside you. It could be in the same room. It could be on a video call. It's also what happens when people are more productive if they go to a library or a coffee shop. So it's the presence of other people that provide a gentle accountability that can really dramatically increase your ability to focus on tedious tasks. There are websites and apps that can help with this where people sign up for a time slot in order to body double with somebody else. And this is something that I did with my dissertation that I didn't even realize had a name, but 2 of us sat down like, we're going to work on our dissertations at the same time. Didn't talk the whole time, but just sitting next to that person really helped. And then all of these can really help us with self-compassion. So really the goal is progress, not perfection. So the strategies, people will forget to use them. A strategy will fail. Looking at it as information, not failure. It just means that that one didn't work for me today, or maybe it didn't work that way. Maybe I can tweak it or I can try something else. It's really about being kind to our brilliant, unique brains and that recognizing that repetition is practice and not a sign of failure. People with ADHD oftentimes don't build habits. We have to think about everything every time we do it. So having compassion that, the same strategy that worked yesterday might not work today, and that's okay. It's really about discovery. So these are just a few of the things that you can find in terms of toolkits for ADHD, and that might be a whole nother webinar as well. So the last one that I'm going to talk about is how do you support somebody with ADHD? First of all, believe them. Take their struggles seriously. Sometimes that's the most powerful thing you can say is, that sounds really hard. I've heard quite a few people, maybe I bring up the idea of a diagnosis of ADHD, and people will say, well, everyone is a little ADD. Well, that's incredibly invalidating, and it really undercuts the idea that this is a neurodevelopmental disorder where the brain is wired differently. Understanding that it's not a motivation issue. It's about regulation. The brain's manager is having a problem. I have spouses that will say, well, if he cared, then he would remember to do this. It's just showing that he doesn't care. It's like, that's not the issue. So this is a way that reframes it with compassion instead of blame. We can also offer specific non-judgmental help, like, can I body double with you? Or, how about you put your laundry away while I'm putting my laundry away? It could be something as simple as that. It's not well, you just need to try harder or put more effort into it. Or if you tried, then you'd be fine. That's not supportive. That's just shaming. And then we want to focus on strengths. Talking about a person's creativity, their passion, their unique problem solving, their ability to see patterns in things. Some of my clients, we talk about being able to see at the 30,000-foot level and as boots on the ground. And so looking at those as superpowers, as strengths that not everybody has access to. Yes, they may struggle in some areas, but they have strengths and talents and qualities that other people don't have at the same degree. So remembering that, letting them hyper focus on their passions at times, letting them really dig into things that are important to them, that can be really helpful. So just kind of the send off, and then we'll look back at the questions. So whether you're here for yourself or someone that you love or someone that you're helping care for, really thank you for coming, for having curiosity, for showing up with compassion today. We're really glad that you're here. We will certainly let everybody know as we do more of these programs. And I will turn it back over to Dr. Bryant. Bailey, do we have any other questions in the chat?
Yeah, two questions. I think one for you and one for Kristen. So the first one is related. Do people get used to clonidine to the point that it no longer works at the same dose? And are there any tips like taking a break?
Yes, people can get used to clonidine so that it no longer works at the same dose. I would say to work with your individual practitioner on that because clonidine can be kind of a dangerous medication if you go up higher on the dose without their knowledge, just because it can drop your blood pressure pretty quickly.
And then the next one for Michelle, this is from another provider who sees a lot of individuals with ADHD who struggle in their marriage because of their diagnosis and the consequences that both the client and the partner experience.
Yes, absolutely. I do as well. One thing that I found really helpful is to talk with the individual as I'm working with them about rejection sensitive dysphoria. That can really help them see that their partner may have a neutral intention or even a positive intention, but it's having a really painful impact on them. Also, I have invited partners into like a psychoed session where I had both people here and we talked about the neurodevelopmental nature of ADHD, why ADHD might start to look worse in later life than it did in school. People are often confused, like, they didn't have any problems when they were in school. Well, there was a lot of external structure in school. There was a lot of accountability. There was a lot of body doubling. You're sitting at your desk next to another kid who's, reading the same book or doing the same paper. So really trying to explain sort of the life course that a person may have and how it really shows up in marriage can be helpful when it comes to working with partners. I don't do the couples therapy oftentimes in this situation. It will really just be like a one-off educational moment for them and to really help the ADHD person stay on task with what they want to say instead of them sort of getting derailed, or if they get kind of what they perceive as a judgmental tone from their partner as they're trying to talk about ADHD, I can step in and try to help temper the rejection sensitivity and help them stay on focus with talking about the illness. I also saw that Holly had brought up that there is a lot of crossover with autism. There is. That's one of the more complex diagnostic testing situations that we see as psychologists is trying to see if a person has ADHD, has autism, or has both. That's a really robust interview. It takes a lot of data to try to suss those out because there is so much overlap.
Okay, well, I think we are at time. Thank you all so much for coming. Thank you, Dr. Kristen Baus of TrueCare Physicians, Dr. Michelle Maegly of Hello Mental Health, and hopefully we will see you all in the future and collaborate together.